Thank you, Nitin. Thank you, Pramod, for the invitation. Can you see my screen and am I audible?
Yes.
Okay. So I'll be speaking about the role of silicone oil in endophthalmitis. I know it's not a standard of care, but over the last 15 years, I've been using it in almost 60 to 70% of cases of endophthalmitis. And I'd just like to show you the variety of cases that I feel it has a good potential and role. Now, endophthalmitis comes in all types. It could be low grade to very small hypopyon, almost clear media with mild fuzziness, to something which goes to a very steamy cornea with a lot of hypopyon, a lot of exudates inside. So one has to actually see a variety of cases and then decide where this probably is feasible. So the traditional approach for vitrectomy, but look at the EVS, there is also a mention of additional procedures. You do a core vitrectomy, and after in the follow-up, you may be dealing with a lot of situations such as a recurrence of infection, secondary breaks, which might have led to detachment, PVR, or a gross hypotony. And then there is management for those kind of situations also. So that's an aspect which we don't usually look at the beginning when we are dealing with just doing a vitrectomy for endophthalmitis. So silicone oil in endophthalmitis, according to us, what we feel is it allows a good cleanup in cases with extensive exudates. You can take liberty to do a very good peripheral cleanup, tamponade the retinal defects in case you have an iatrotic break or a missed break, which was there because of the inflammation. And anyways, breaks are more likely in these inflamed eyes. Contains any inferior detachment till the eye is quiet so that you can tackle it later. Otherwise, it goes into a very early PVR. And with inflammation, it's difficult to tackle it very fast and prevents severe hypotony in the post-operative period. So these are extensive exudate in the periphery type of cases, which could, where if you just leave them after doing a core vitrectomy, they lead to a lot of other problems. And of course, literature does talk about the inhibitory effect of microbial growth and reduces the recurrence rates. And there's a lot of data on that as well, which is there. So we had published our early experience in 2000, where we compared a large group of patients which we had done core vitrectomy versus core vitrectomy with silicone oil. I'll not go into details for paucity of time, but essentially we looked at, compared a lot of things, including visual acuity, recurrent surgeries, any requirement of additional procedures, control of infection. So this was the kind of numbers that we had: 63 in core and 55 with oil inside. We also had a post-traumatic subgroup, which of course, is a different aspect, and it was a part of this study, but we had put subgroups to them while discussing it. So these are examples of cases which had sort of a low grade enough. If you see, there are opacities which you have intravitreals earlier, maybe have resolved to some extent, then there's recurrence, so you go in. A lot of PNS type of infections you go in. So these, of course, we resort to typically a core vitrectomy, while those which are peripherally spread out fungal or have exudates in the periphery, we like to do a full-fledged vitrectomy, where we would also like to peel and remove everything. And this liberty you can take if you know that you're probably going to put oil inside. These kind of cases where you have this whole peripheral area which is totally blocked with exudates. And if you leave all this just by clearing the central part, all this is going to bring in possible recurrence at the end. Now, this is a case of a steamy cornea with hypopyon also there, and of course, posteriorly there's exudate. So first of all, we clean up everything anteriorly. We remove these organized membranes which form with the hypopyon, and then of course go back inside. And you can see that this is the kind of case which I showed you earlier with low grade one. So this is exactly what we take as a gross distinction, where we decide that, okay, this is a case where I will like to put oil, and I will go as much of a cleanup as I can, take the liberty to remove hyaloid, remove as much, and then put oil and follow these cases up, rather than not put oil in these cases, because otherwise here my visibility is not great, and I'm going to leave behind a lot of stuff in case I'm not confident of putting oil inside and make it breaks, and or there may be a detachment and I'm not happy, or there may be a hypotony or a recurrence, and the compartmentalization.
Manish, you'll have to wind up first.
Yeah. So these are, I mean, I basically wanted to show you that these are the different varieties of cases. And so the 60 to 70% of cases of these sorts is where I would typically put oil inside, while others I would